Hello, I'm Malcolm Robinson. I'm just about to set off to the first place I died. Why don't you come along on this journey with me? You never know, you might find it interesting. Well, I've reached my destination. I've come to Birmingham, to Digbeth area, and this is the site of where I had an out-of-hospital cardiac arrest on Easter Saturday in 2017. Prior to my cardiac arrest, my wife Anne and I had been exploring the canals in the Digbeth area of Birmingham, scouting out a route to take our rambling group on. As you can imagine, this would not have been the ideal place to suffer a life-threatening event. In fact, it's very doubtful I would be alive today if my cardiac arrest had occurred on this towpath. On leaving the canal, we then visited one of Birmingham's famous sites, where, in 2014 and 2016, the City of Colours street art festivals transformed Digbeth into one of the world's largest outdoor art galleries. But this isn't a tourism promotional film, so it's time we headed back to where the serious stuff happened. The reason I've come here today is to meet a very special person in my life, and you're about to find out what makes her so special. So she's not here yet, but I'm hoping she'll appear very soon.
Hi Malcolm.
Hello Judy.
Hi, how are you Malcolm?
Thank you for coming along.
Good.
So Judy, let's start off by you telling us a bit about your background.
Okay, my background is I've been a nurse since 1981, qualified in London, worked in various positions in London, got a great experience at the National Heart Hospital in London, where they did do heart and lung transplants. Came to the West Midlands, worked on various units and wards. Then I became a sister on the community as a community nurse, and then a nurse practitioner within a surgery.
So now can you give us a brief synopsis of what actually happened on the day where you first met me on this site?
Yeah, certainly. I dropped my daughter off at the railway station. I'd parked not far from here, got into the car, and as I drove past the entrance to here, I basically saw a lot of people around, but I could see your feet sticking out. So obviously I thought there's someone's collapsed. I asked if there was anybody medical available to help, and they said no one was there. So I quickly got out the car and came over to you, asked if anyone had called an ambulance, and then started to think, right, this man's in serious trouble. So you had a backpack on your back and you were in an awkward position. So I needed to get you onto your back, to check your airway, check your breathing, and then I started CPR immediately.
So I wasn't breathing when you arrived?
You were not breathing, no.
And I heard about the ambulance not coming very quickly.
Yes.
I did meet the crew.
Right.
And they did tell me that they turned up within 3 minutes.
No,
not at all. But that was a different call,
yes.
I think.
No, not at all.
It wasn't prioritised, was it, the first?
No, because one of the girls, luckily someone had phoned an ambulance because they thought you collapsed. One of the girls that said she had called an ambulance, however, she did tell me when I said, how long are they going to be? Because I was doing CPR for quite a long time. I said, you need to call again. And she said had told them that you were breathing, which you were not.
So you're saying that the bystanders who were just standing around weren't actually doing anything practical to save my life?
Not at all, no. Apart from filming.
Well, if you hadn't, they're filming? Yeah.
Yes, they were filming you on their phones.
I wonder whether that ever made it onto social media. I never saw that myself.
Oh, right, okay.
No, but it was a shame that people do that. in a way.
Yeah,
I
some
wonder-
people, some people do it out of fear and stand there and don't know what to do,
Yeah.
which is, you
Yeah.
know, why we're here to talk about CPR and stuff. But yes, it was just sad to see that people were filming it.
I understand
respect.
that you weren't alone in helping me then. Somebody else appeared?
I was alone for a good maybe 20 minutes, and then a gentleman came and said he's not medical, but he has got first aid. He asked if he could help, and I certainly wanted his help by that stage of 20 minutes doing CPR.
We've never found out who he was.
No, and it's a shame
When
because
back
it was very
then my
helpful.
children spent a lot of the time trying to trace
Yeah,
him through
yeah,
social media,
yeah.
and I put out a big call on
Yeah,
Twitter, but
yeah.
never had any idea who he was.
No.
And I hope he might see this. If you're watching this, you were here on Easter Saturday 2017, and you happen to see this, and you were one of those 2 people who saved my life, we'd like to hear from you.
That'd be great.
You can go to the website that you'll see on the film and send me a message. I just don't know if that'll happen.
Well, it'd be lovely if it did.
Is
It'd
there
be
anything
lovely
else
to meet him.
anything else you can add to the story at this on the day here?
No, I think, as I said, I started CPR. His help was very
Yeah.
welcomed.
Yeah.
2 ambulances then eventually came, and they continued then to. I continued with CPR, and they got to defib you while you were here,
Okay.
twice on the floor.
Okay.
Yeah,
Well, thank you, Judy.
you're more than
I think we should
welcome.
have a big hug now. I counted myself as the luckiest person alive that day when I survived my out-of-hospital cardiac arrest, thanks to Judy's intervention. But victims shouldn't have to rely entirely on luck alone to receive the basic life support of that first link in the chain of survival. In an ideal world, any one of those bystanders who were watching and filming me on the ground would have been able to start that chain of action. If you were watching this, would you have been able to step up to the mark? Free training is available all over the country. You just have to seek it out. You'll never regret it. Hello again. You probably realise I'm in an ambulance here, and I'm at Erdington Ambulance Hub in Birmingham, and I've come here to meet Cameron McVitie, who was one of the crew who attended my out-of-hospital cardiac arrest back in 2017. Hi Cameron.
Welcome. Great to see you again.
Do you remember any of that day?
Yes, so albeit 6 years ago now, since your out-of-hospital cardiac arrest, I was working as a paramedic with my crewmate Tom on the day, and I remember attending your incident, obviously on the streets of Digbeth. I do, yeah.
Yeah, and you had other 2 from another ambulance with you, Simon
That's
and
right.
Robert.
Yeah, so Simon and Robert were from a different ambulance hub. We were the 2 nearest resources at the time of the 999 call, which was placed, and we were the first ones to arrive on the scene.
So I came along eventually to meet you at Hollymore Hub after 20 months of trying to trace you, and I met the 4 of you, and then also I met up with Derek Connolly there, who was my cardiologist, and we all met together.
Yeah.
And there's some pictures of that which will appear on the screen, I'm sure.
Yeah.
So can you take us back a little bit to that day? What happened?
Yeah, it was a normal day at work for us, for myself and Tom on the ambulance. We'd attended numerous cases before the one involving yourself. I can't exactly remember where we were at the time of receiving the 999 call, but obviously we were in close proximity to Digbeth. We remember obviously receiving the call, and when we arrived on scene we saw a member of the public providing what we call bystander CPR. So some simple chest compressions to provide you with the best chance of survival before our arrival, to start off that chain of survival, before we can continue that care.
That was Judy Lewis, who has also appeared on this documentary in the previous section, and she was the first and second parts of my chain of survival. So you came along as the third part, and then you obviously did what you had to do. What did you actually have to do briefly?
Well, we're very lucky in the UK that paramedics are trained to an extremely high level, and especially in realms of out-of-hospital cardiac arrest, where we can provide advanced life support treatment and ultimately bring elements of the hospital treatment to the patient. So obviously pre-hospital care has changed vastly in the recent years and recent times. So we're very fortunate we were able to do that. Very quickly established the circumstances surrounding what had happened. After a brief conversation with Judy, we asked if she was happy to remain at the scene and assist us until the arrival of other resources, albeit that second crew that came to help. And then we go into our own algorithms and our own set procedures as per our guidelines for the paramedic practice.
Well, it's interesting you say that, because waiting in the wings for us is another set of your colleagues who are going to take us through a full-scale demonstration of what actually happens at the site of these cardiac arrests.
Yep.
And would you mind if you gave a bit of a voiceover to that to tell us what's happening?
Yeah, of course, it'd be great. I think it'd be really informative to let people know exactly what would happen at the scene of an out-of-hospital cardiac arrest. So yeah, we'd like to do that.
I must say, I was surprised at how much goes on. There's so much equipment and so many different people doing different things at the same time.
That's right. I mean, so the procedures and the treatment has advanced, greatly in recent times, and we try to think of it now as a pit stop approach to out-of-hospital cardiac arrest. Everybody has a role, and there are checklists to go by to make sure that we follow the correct procedures and no stone is left unturned to give the patient the best chance of survival.
Well, I can certainly say it works, but not very often that it does work, does it? There's so many don't survive for one reason or another.
Yeah.
What would you feel is the main reason? Is there one you can give? Poor survival rate?
I think in our country we need to make sure that we get better at training people in terms of providing CPR and that basic life support before the arrival of clinicians such as myself and my colleagues to enhance that level of care to give the patient the best chance. So,
well, as you know, that's what this film is all about in a way, to encourage people, get out there and find a way to learn how to do this.
Absolutely.
We're doing our best in Sutton Coldfield.
Yeah.
There's a whole country to go through.
Absolutely. And it's fantastic to see what the group has done and achieved since your out-of-hospital cardiac arrest. It's a fantastic achievement. We're really grateful to yourself and the members of the group, and you've done a fantastic job.
I can't imagine how disappointed it must be for people of your own profession to get there and find it's too late to revive the patient.
It can be very difficult. Obviously, we take every job as it comes. The advantage to our job and something that keeps us on our toes and keeps us enthusiastic about our role is that every job is completely different. No job is the same. But you are right, it sometimes is very difficult for us to process and does take its toll emotionally and mentally on ourselves when we do unfortunately attend incidents where we are unable to provide assistance and obviously unable to successfully resuscitate patients despite everyone's best efforts. So yeah, it can be difficult.
Yeah, I can imagine. Well, shall we move on? We'll go over to see what's going on where the other crews are putting together this demonstration for us. So I'll see you over there.
You will.
Thank you. Right, hello, you're Adam, aren't you?
I'm Adam, yes.
And where are we?
So we're at Ardington Ambulance Hub in Birmingham.
Oh, okay, and so you've volunteered with your crew as well to show us something special, haven't you?
Yes, so myself and 4 other members of ambulance staff and a community first responder have come in to show an advanced life support scenario, pretty much what you would have received on the road when you had your cardiac arrest.
And this will be on a mannequin?
Yes, it will be.
Right, because it's probably not a good idea to practice all this on a real person. Do you ever practice on real people?
No, we never practice, unfortunately.
So you have a crew here, a team of people who've come here in their own time to do this for?
Yes, they've all come in extra to try and support
really
this.
Fantastic. So shall we get on and see what you've got to show?
Let's do it.
Thank you.
So you can see when the first responder enters the room, he is already starting to assess the scene and assess the patient. He's establishing their level of consciousness, whether they are alert, whether they respond to verbal or painful stimuli. And in this scenario, the patient is unresponsive. Now needs to establish some airway patency and check if the patient has a pulse. He wants to protect that airway with a simple airway adjunct, which is known as a OP airway, an oral pharynx airway. And then CPR is commenced. So it's a very quick start with CPR for that basic life support algorithm until further help arrives.
Hi Ben, you're
Hi, mate.
What's happening? What we got?
Unknown age, been down for OP airway in. It was asystoly when I got here.
Okay, you just hold for a second for me.
Yep.
it's a fairly seamless transition into what they have to achieve. Crews are very well versed on where equipment should go, what equipment is needed in what order, and then we will go into the advanced life support algorithm as quickly as possible. So you've generally got one person who will assist with airway management and one person who will attach the defibrillator pads to establish what rhythm the patient's heart is in, to establish whether that's a shockable or a non-shockable rhythm.
If we just move this here, I'm going to get this airway changed, okay.
It's important to note here the positioning of the clinicians, noting the
Shock result now.
CPR provider, someone at the airway end who can control the patient's airway and oxygenate and ventilate the patient.
Okay. Shock delivered back on the chest for us.
Lovely, now we've got a few extra pairs of hands. We're going to do 30 compressions to 2 ventilators.
Hello guys, I'm doing.
Hello guys. You're right.
Okay.
That's fine.
And as more clinicians start to arrive, further interventions can be provided. So here what we're starting to see is the emergence of a team leader
Greg, if you can get your reversible causes, if you can get
who will coordinate the interventions being provided.
in a moment.
Right, we're going to get 2 ventilations in, mate. 3, 2, 1.
This is where the patient's being oxygenated,
And I want you to count when you get to 5 rounds.
providing those ventilations in between 30 chest compressions.
Of course, mate.
So the clinician nearest to the screen is now
If you grab an easy seat.
establishing intravenous access to provide some
25, 26.
medications specifically for use during cardiac arrest.
Okay, let's go back.
And there's a strong emphasis on continuous
Cheers, buddy.
chest compressions, which is why the basic life support and the chain of survival is absolutely crucial with regards to those chest compressions acting as the patient's heart trying to effect a beat.
Okay. Lovely, keep going.
So we talked about the emergence of that team leader. That team leader is now going through a specific checklist.
Guys,
The use of a checklist has emerged from aviation, again relating back to human factors, making sure that everybody has a role,
nice 360
that
degree access.
very pertinent
29, 30.
actions have been taken. For example, the application of defibrillator pads, and these sound like very, very basic things to cover, but it's important that we make sure that they are in place and effective so that no mistakes are made and the patient has got the best chance of survival.
6.4 for the end, guys.
25,
The clinician at the airway end is now preparing to what's known as upgrade the airway. We have a range of airway devices which are available to us in the pre-hospital environment. You see here that he's using what's known as a iGel device, that's a supraglottic airway, which is used just to protect the patient's airway much better than that basic adjunct which was used at the beginning of the scenario.
Keep going.
From here we can monitor the patient's end-tidal CO2 readings, which give clinicians important information with regards to the quality of CPR and any changes in the patient's condition.
Yeah, happy to go.
So just to rewind a little bit, we're going to go through that upgrading of the airway in a bit more detail. Oxygenating the patient with effective bag valve mask use.
I'm going to get this iGel in.
Removal of the simple airway adjunct, and then the insertion of that upgraded airway device once it's been appropriately prepared. Noting importantly that the chest compressions are ongoing during this process and nothing should interfere with that and interrupt that apart from defibrillation.
Okay, keep going for me. We're going to insert it now. Okay. Okay, mate. No worries.
And that airway is then successfully inserted and the airway circuit is connected with the correct monitoring and oxygen reapplied
Okay, when you hit
with a
30,
check
let me know.
of how well the patient can then be ventilated. This is then secured, obviously in the pre-hospital environment when the patient is transported from the floor to the stretcher to the ambulance, ambulance to the hospital. There is a high chance and high risk that this airway can become dislodged, so we need to secure it properly.
So, defib pads are on. Was a shockable.
So you see here the pit stop approach that we like to take. It may look like some people aren't doing things here, however, they are keeping a close eye on everyone's activity. The team leader going through the checklist and those actions. Continuous chest compressions being provided. Someone looking after the airway and someone looking after the intravenous medications that are given to the patient.
Cool. And we've got a second crew here as well.
It's really important that the team really goes through this checklist. It picks up other important things such as the welfare of the CPR provider, whether we need to change that person as they become tired and chest compressions become less effective.
That's fine. So what we're going to do, we're going to come up to the end of this cycle, we're going to reassess the rhythm.
And this maintains everybody's situational awareness. Everybody knows exactly where we are in terms of the treatment being provided.
Count us down in your last 30, mate.
And everyone has a chance to raise concerns or offer opinions on the treatment that needs to be provided from any point.
Okay. We have got a rhythm change.
So we know here that the patient's rhythm has now changed.
Okay. Can we feel for a pulse, please, guys? Do we have a femoral at all? Yeah.
Got a femoral,
Is
yeah.
that a pulse? Yeah. Okay,
Yeah.
guys. So we have got a pulse. So let's reassess ABC. Airway. Are we happy with airway?
When the patient has a return of spontaneous circulation known as a ROSC, which is what we are aiming for here, we then go into providing
So we'll carry on
post-ROSC care, which is essentially going back to the beginning of the treatment algorithm, assessing the airway, breathing, circulation, as well as some other interventions such as a ECG or an electrocardiogram, which gives us a reading of the patient's heart activity. And from here we can establish whether the patient needs to go to a specialist receiving hospital such as City Hospital in Birmingham, where we can perform some advanced interventions. So the patient is obviously transported to the ambulance. It's important that we check everything again once we get into the back of the ambulance. You see the crews here going through the motions of putting the monitoring back onto the patient. There's a lot of wires involved here, so it is important that we have some sort of organisation to this wiring. And you may notice there's not a lot of communication between the crews, and this is because they train for this and they are well drilled and well versed in what they have to achieve. One person looking after the airway, one person establishing the monitoring.
Hello City Hospital, I've got an alert for you. We have a post-ROS and we are about 10 minutes away from yourselves. Cheers, thank you.
And another person will then provide what's known as a pre-alert to the hospital. This is to put the hospital on standby so that they can collect the appropriate clinicians from different departments. That may be neurology, cardiology, surgeons who are in the department ready to receive the patient when the crews arrive at hospital. And this then just minimises delays in the patient's ongoing care. Final checks are completed before the ambulance departs, making sure everybody's safe and secure, including the patient in the rear of the vehicle. And then the patient will depart. And the whole process is done in reverse upon arrival at hospital, and the patient is then handed over to the emergency department with clinicians in the resuscitation area.
Let's turn the lights off.
I'm back at City Hospital, Birmingham, where the ambulance crew took me in April 2017, in an unconscious state after my out-of-hospital cardiac arrest. I'm heading for the catheter lab to meet Professor Derek Connolly, the interventional cardiologist, who became the provider of the fourth link in my chain of survival. Hi Derek. Can you remember that day, 15th of April 2017, when I was brought in unconscious after a cardiac arrest?
I remember it vividly. We normally do a semi-elective urgent cases on a Saturday morning, and I was just about to finish, and I got a call that there was someone coming in with an out-of-hospital cardiac arrest. And we brought you in, Malcolm. You were unconscious, you were ventilated, and we looked at your arteries, and as you can see over my shoulder, you had a blocked right coronary artery, which we opened up. It's a very big vessel, much bigger than the average. And I remember coming out, taking you to the intensive care unit, and then talking to your wonderful family.
Can you show us what the pictures mean up there?
Yes. Well, this smaller picture, you can see there is a blocked artery. And after a few minutes, a wire, a balloon, a stent, you can see this enormous artery, probably supplying around 2/3 of your heart with blood. So opening that saved your life.
If a person suffers from high blood pressure or hypertension, diabetes or high cholesterol, or is a smoker or has a strong family history of heart disease, deposits can build up inside the arteries in the same way limescale develops on the inside of a pipe. This can cause severe symptoms of chest pain or angina. If this narrowing continues, the vessel may be cut off altogether, leading to a heart attack. One way of restoring the flow of blood is a treatment called angioplasty and stenting.
Angioplasty, primary angioplasty, really only came about 20 years ago. We were one of the first centres to do this in Europe. And we massively reduced the number of people dying from heart attacks when we did this. But it's 7 days a week, it's 24 hours a day. There were only 700 people doing this in the whole of the UK. So it's very demanding. But look at the rewards. But of course, it goes on, and you're taking all those medications, you're living all those years because of the therapies.
Of course, all the staff and the nurses, everybody who kept me on the ward for 11 nights, that's all part of the picture.
It's a team game, and lots of people are in that chain.
Well, thank you, Derek. Thank you for taking the time to give us a little insight. Is there any way we could go and look at the cath lab?
Absolutely.
Where it all happened?
Let's do that now.
Yeah, thank you. So, Derek, this is what we call the catheter lab.
Absolutely. This is where you came. And you would be lying there, your head would be there, your feet would be here. We'd see the screen to see the angiogram. This is where we operated on you.
Yeah. I can't remember any of it at all. Did I come round at all?
Not in the slightest. You were unconscious the whole way through. Oh, and of course, the intensivist took you from here, after we'd operated, to the ITU.
The best sleep of my life. I've never slept so well since. So, just describe a little bit of what you did here.
So we went in from your wrist, we went up to your heart, we put catheters in, we put the wire down, we put a balloon down, stretched the artery, we put a metal cage called a stent in to hold the artery open. We give you lots of drugs to keep it open, and then we send you to ITU.
It's a minimally invasive procedure performed by passing thin tubes up towards the heart. We usually go through the wrist, which reduces the risk of bleeding and allows the patient to recover much sooner. The thin wire, about the width of a human hair, is positioned inside the clogged artery. Then a balloon mounted on the wire is passed across and inflated to expand the narrowing, creating room for the stent. The stent is a small mesh tube that helps keep the vessel open. The balloon is then withdrawn and the stent carefully positioned. This restores the normal flow of blood.
And this is all part of the gear that...
This is X-rays. So we X-rays to see through the body.
Yeah, fantastic. I remember the second time I came here, I could see a screen above me.
Yes.
But they didn't do anything then.
Yes.
They decided whatever they saw wasn't... They were thinking of putting another stent in.
Well, the right coronary artery had been successfully stented the first time. We did a good job.
Yeah. And they've been there ever since. Right, thank you.
I'm Dr. John Hume. I'm a consultant in intensive care medicine and anaesthesia, and I'm currently the joint clinical lead for critical care services here at City and Sandwell Hospitals. As a consultant in intensive care medicine, we see a lot of patients who come to us after a cardiac arrest, and those patients who make it to the emergency department with their heart beating and resuscitated are the first group of patients who might be survivors, which is good. Because without that being done outside of hospital or by the ambulance service, then we can do nothing more. On intensive care, we send doctors down to the emergency department, and they form part of the team that look after patients who come in, and will then look after those patients as they go to the catheter lab, where we provide anaesthesia and support for breathing and blood pressure, as the cardiologists do their bit to try to open up the blocked vessel, which is often the reason why the heart has gone into cardiac arrest. It's often a couple of hours worth that the cardiologists need to spend in the catheter lab, and then after that people come to us in intensive care, and almost everybody who's had a cardiac arrest out of hospital who's got to that point is not fully conscious, And so many patients that come to us on intensive care do so with a breathing tube down their windpipe, on a life support breathing machine, and needing various forms of support. There's a very small number who look as though they're waking very well early, and if that's the case, then we can, as long as everything else checks out okay, turn off the sedatives that we're typically using and allow that person to wake up and then take the breathing tube out. But that's not the case for most people. And for most people, what we then do for the next few days is to make sure they don't overheat, because being too hot is bad for the injured brain. So we can often actively cool people, or if not, very much make sure their temperature isn't rising too high. To make sure the breathing's controlled, to make sure the blood pressure's controlled, and the important salts and other minerals inside the body are at the right level. And then for many people, what we do is to spend 3 to 4 days doing a whole range of tests, including scans, EEGs, their brainwave tests, and other blood tests, to see if it looks as though that person's brain has been injured beyond repair, or if there's cause for hope. And what was really good to see was that in Malcolm's case, those tests didn't come back as being excessively bad, but instead said that we should continue and see what happened from there. And if that's the case, then time is the greatest diagnostic tool that we have. And we were then able to reduce the sedation and see how he woke up. As most people do after that amount of time, particularly if there's been a problem where the brain's been injured, as it often is with cardiac arrest, then when we take the breathing tube out, often people like Malcolm are very confused at first and leave us from intensive care a few days later, even having been free from the breathing machines for a few days, still confused and certainly lacking memories usually, and having had no idea or no clear, able ability to recall what happened on intensive care. But then go to a cardiology ward where various medications are started or tweaked in order to try to make the heart health after that time as good as possible before being discharged from hospital. So in the chain of survival, intensive care comes towards the end, but it is the important 4th or 5th link in the chain of people getting better.
The only thing I can remember from my stay in there, which was over from the Saturday to the Monday, and I was unconscious throughout, was the noise of the machines going tinkling up and down in like a rhythm. I kind of had a dream where they entered that dream and gave me some sort of, I suppose, hallucinogenic sort of pictures about what was going on with these noises. Is that common that people hear but not conscious?
It's extremely common. So we don't give people enough sedatives to try to make you profoundly unconscious and completely out of it for all the time. But because they're drugs that affect your level of how awake you are, and also the brain's taken a hit because of its lack of blood flow during cardiac arrest, then people interpret the noises from the ventilator, the alarms from the pumps, what people are having done to them. So when the nurses are caring for you and washing you, and lots of different scenarios, people create images in their head of what's happening, and often they're very removed from what actually is happening. So yes, very, very common and quite confusing for many.
I don't remember it at all, but I'm told that when I was released from the induced coma, and obviously you'd cool me down, I went into violent shivers. I must have still been pretty cold when I was woken up. What temperature do you lower the body to?
So you wouldn't have been cold when we woke you up, because we'd have allowed you to re-warm up to a normal body temperature. But we keep the temperature now between 32 to 36 degrees centigrade. It used to be colder, so when you came to us, the guidelines were a bit different, and we'd have held you between 32 and 34, which is pretty chilly and pretty unpleasant in anyone's book.
Yeah.
And whilst we're doing that, those are for patients who are the most unconscious, is that we do keep you then heavily sedated, because shivering, as well as being unpleasant, also is intended to warm the body up. And if we're trying to cool you down, having somebody shivering, trying to warm themselves up, it is counterintuitive and against what we're aiming for.
So I must have been shivering for show.
Maybe so.
Yeah, because I've got to make the most of this.
Some of the medications as well make you shake.
Oh, right, could be that. Yes, as I say, I don't have any memory whatsoever other than those noises. I was taken from there. I wasn't kept any longer than the 2 days. I was taken out to the ward down the corridor, where the next 9 nights I spent the time amongst a lot of other heart-related patients.
Yes. It's very common that people who've been with us as patients don't remember it. I think the memories are usually imprinted on the people, like your wife who was with us and other friends and next of kin who've been there.
I'm surprised you say you remember me. I don't know, what was it about me that made you remember?
I don't know. Most of our patients stay with us for 3 to 4 days. So people who stay for longer than that, a week or more, are reasonably long stayers, and there are faces that you remember as you go through.
Well, you had to get me out pretty quick, so that's why you remember me. Get rid of this or so. Well, thank you for coming along and telling us about that.
That's okay, my pleasure.
Is it possible we can go and have a look at the place where I was kept?
Of course, yeah.
Thank you.
It's okay.
So, John, tell us what's going on in here, or what happened when I was in here.
So this is one of our intensive care bays. They're, they have no patient in at the moment, but set up ready for a patient should they need it. And intensive care is a really technological area with a lot of machines and information and drugs and infusions to look after some of the most seriously ill patients in the hospital, as you might expect. On the whole, it's generally calm, quiet, with sort of background noise for us, but I know that you said that some of those noises had stuck firmly in your memory, and the noises that we generally hear on intensive care from the machines are ones that are telling us that the drips need some attention, or the life support ventilator breathing machine is telling us about something happening that it wants us to know about. Other than that, we try to keep noise to a minimum because otherwise it becomes a cacophony of noise that's just overwhelming and you can't pick out what's important. So the sort of things that are in here include lots of cabinets for some of the kit that the nursing team looking after patients are going to use. There's a fairly small number of pumps on here at the moment, but they're pumps which include ones that push liquid feed through a tube that we put down via the nose into people's gut, so that even though they're unconscious on a life support machine, we can put feed into the stomach, and some of these pumps push that down. Other ones like this push fluid into the drip, so that we can give people different drugs and solutions. And then the pumps like this are ones that we use in order to put the syringes in, and they're the ones that we would have used to give you a combination of medications to keep you unconscious whilst you were with us for several days. It's very technological, and we have this is a smaller laptop, but we have larger screens on which now all the patient records are kept, and we can review the observations and details and drug charts and make records in there. So we've now, for the last few years, moved away from having any paper records, and now everything is on computer that we can access from around the hospital. And then what's beeping away at the moment on the other side is one of our ventilators, which is ready and waiting for somebody should we need it. So it doesn't have all of the breathing tubes connected at the moment, but as well as the monitoring that we'd use in order to keep a check on people's vital signs, then this is one of our life support machines, which is what it's, from a layperson point of view, would be called a life support machine. It's a ventilator, so it's a breathing machine that we can use in various different ways to take over people's breathing and give you extra oxygen when you're unable to breathe strongly enough for yourself. And it has tubing connected to it that then gets attached to a plastic tube that goes in, usually through the mouth, and goes down into the windpipe so we can take over breathing. A few of our patients who stay for longer and need breathing support for a longer time, we swap it so that the tube goes through the front of the neck. That's called a tracheostomy, and then we can attach the breathing machine to the front of the throat. And because that's more comfortable, then people can tolerate that without the added sedation, whereas having a tube in through your mouth, down through your voice box into your windpipe is quite uncomfortable. I'm happy to say that because you were only with us for a few days, then we're able to take you off the life support machine before then and just take the breathing tube out and then let you breathe on your own.
Well, thank you. That's a great insight into what happened, which I've got no memory of. And this is the actual bed, you think?
You were on this side of the unit, so I think your bed space was the one of these three. I certainly remember you being on this side of the unit when you were with us. Yes.
It's all very strange to me.
I can imagine. Yes.
I used to work in an intensive care unit when I was first qualified, so things have changed an awful lot. I don't recognise any of this machinery. I'm talking about 50 years ago. That's great. Thank you very much.
My pleasure.